So we will have two presentations from Dr. Bertani and Professor Schalke van der Merwe. And afterwards, we'll have the time to discuss some questions and and to discuss with the audience. So I guess we will start with the first presenter from Modena, from Italy, Dr. Bertani. Thank you very much to be here.
Thank you so much. I'm sorry to not be there with you due to the strike. I'm stuck at home. I can share my screen. Thank you for the invitation to Dr. Giovannini. It's a great pleasure for me to be invited to this inspired meeting. And also a pleasure, and I'm honored to have as a co-speaker and to share this stage with Professor Schalke van der Merwe, one of the author and of the guidelines, European guidelines on therapeutic endoscopy. What are we talking about is about the use of enteroenteric anastomosis in cases of altered anatomy. And the first report of this kind of procedure was in 2015 from the group of Bean Moller in a patient with apparent loop syndrome. And since that we have arrived to a therapeutic approach with the endoscopic ultrasound, thanks to the development of technology. First of all, endoscopes with the increased maneuverability, with a smaller tip, a huge wide field of view, and a big working channel with the possibility to introduce devices into the working channel. And moreover, the use of lens, the first dedicated devices to therapeutic endoscopy. I will stress 1 minute to the lens because this is the first dedicated devices to therapeutic endoscopy. This is a very short saddle-shaped stand with the huge distal and proximal flanges that reduce the risk of migration of the stent during the deployment, but also the silicone coated, which reduce the risk of leakage during the creation of the anastomosis. Moreover, the cautery tips that with a single maneuver can introduce the tip of the stent into the target organ and to release in the same time. In the last 6 months, European Society released 2 interesting papers about the use and the guidelines of therapeutic endoscopy in gastroenteric anastomosis, enteroenteric anastomosis, and describe and stress our attention about the need of a minimum requirement once we approach to this procedure. First of all, the anesthesiologist is in the room, because this procedure is a procedure in which we connect 2 different lumen and 2 different organs, and sometimes the risk of inhalation for the patient is high, and so it is suggested to perform this procedure with the protection of the airways. Moreover, CO2, of course, a linear therapeutic EUS, and a fluoroscopy. Fluoroscopy is not a tool, optional tool, but is a mandatory because it can help during the procedure, but also in case of this misdeployment of the lens, it can help to a salvage technique. Then we can, of course, have lens that is has to be bigger than 15 millimeters, and I will explain to you why. Also long guide wire, cannula, nasobiliary drainage, and saline solution that you can inject with a water pump or syringe with methylene blue and contrast medium. This is the minimum required before starting with the procedure. The concept of altered anatomy is considered everything that can stop our procedure. It cannot permit us to reach the target organ, and could be a post-surgical reason, like you can see here many surgical reconstruction with Roux-en-Y bypass, gastroenteral anastomosis, everything that make us impossibility to reach the target. And before starting with this procedure, we need to know the anatomy, because we have to know which is the limb that is closer to the organ target to our procedure. But moreover, it could be also for luminal obstruction that is not only for neoplastic region, but sometimes is due for benign lesion, like a duodenal hematoma, or like acute or chronic pancreatitis. And so many options are in our desk. But it's we have a need to create a gastroenteral anastomosis, or we have some technique. Nowadays have been described many techniques. Nodes and endoscopic magnetic compression are reserved in tertiary care centers and not so diffuse. But surgery and enteral placement are our standard of care. Surgery, of course, is not for all patients because it's an invasive technique, and not all patients are fit for surgery because in oncologic patient is too invasive, or there is a peritoneal disease that make surgery not possible. And so we used, and we are still using, enteral stent placement in the majority of these patients. However, we know that sometimes it's difficult to place a stent, usually in the jejunum or in the third duodenum, and the long-term efficacy of the stent is limited because the need of intervention is higher, and also the relief of symptoms is not so good. There are also some short-term possibility like a nasogastric tube, the PEG-J, or the balloon dilation, but there are short-term, and moreover for patient, food intake is not allowed. And so the definition of gastroenteric anastomosis is a definition of where two walls of two luminal structure are closed and by the placement of a lens, and we create a fistula under endoscopic guidance. Once again, ESG guidelines suggest to perform in expert hands because adverse event, as I will show you tomorrow later, is not so low, but moreover recommends a multidisciplinary discussion before starting with this procedure to understand if it's the better procedure for the patient that we have. The first procedure I will start with the EDGE procedure, Obesity is a huge problem all over the world, and renal gastric bypass is becoming more and more popular, especially for young patients. However, these patients usually in their life encounter pancreatic and biliary disease, and the access to the duodenal region and the pancreatic region is very difficult. Up to now, we have two techniques available. One is in the enteroscopy-based ERCP with a single or a double balloon. It takes a lot of time, and reaching the ampullary region is not so easy. And the lap-assisted ERCP, that is invasive technique in a patient who also who underwent surgery before, and sometimes laparoscopy is not allowed. And what is the EDGE technique? The EDGE technique is a creation of a fistula between the gastric pouch or the jejunal limb and the excluded gastric stomach with the use of lamps. This is a video very fast, just not to get you bored, and in which, I hope you can see it. Okay, in which we identify under EUS vision the gastric fold. We puncture the excluded gastric with an N19 gauge FNA needle. We inject saline solution and contrast medium. Under X-ray, we can see the gastric excluded, and we insert the guide wire, and through the guide wire we insert a lens. Then we dilate the stent in order to introduce the duodenoscope, and then through the stomach to reach the excluded stomach, to reach the second duodenum, and to perform ERCP in a standard. Then we have a lens. We have to remove lens, and we have to remove later, not immediately, and we can close with the suturing system, OTSC, or with Apollo, the fistula. And the results, two series have been published last year, a great series with more than 100 patients, with a successful ERCP in more than 90% of cases, a lamps placement in 98% of cases. But we have a 10% of migration of the stent and adverse event around 15%. Compared with the enteroscopy-assisted procedure, we see that the performance of the EDGE is much better, because in 100% we perform the RCP compared to 60% of double balloon, and the adverse events are similar, but double balloon ERCP is of course longer. And compared to laparoscopic assisted, the results are not so different, and that's good. And of course, the time of the procedure in the laparoscopic assist and the invasive of the technique is higher. But there are many open issues and many things to discuss, and are work in progress about this procedure. Most of the first is that the series are retrospective and now are going all the prospective study. And one is the possibility to perform in one step the procedure, and so to create a fistula, to place a lamp, and to perform RCP in the same session. Of course, if we can wait, it's better, because the risk of dislodgement or displacement is lamps is higher. And so if we can wait because patient's condition allow to wait 1 week, it is better to wait. Moreover, the risk of lamp migration has been reported around 10%, but up to 16%, and is not only intra-procedure, but also delayed. And so the diameter of the lens is important because it is suggested to use a 15 or bigger lens. And in this case of procedure, the 20 millimeter is preferred in order to reduce the risk of migration during the procedure. And it's not so easy also to find the perfect place to do the edge procedure, because under EUS, sometimes you are too close to the antrum region. And so the movement of the duodenoscope for the subsequent RCP is difficult and is not possible to reach the second duodenum in easy way. Moreover, some issue about the closure of the fistula. The patient underwent a gastric bypass to lose weight. If you will leave open the fistula, because in many cases the fistula still is open after months, the risk of gaining weight is high. And these are all topics under discussion, and we will have results in the next years. Another condition that benefits of the therapeutic EUS in altered anatomy is afferent loop syndrome. Afferent loop syndrome is defined as the obstruction, mechanical obstruction of the afferent loop in patients who underwent pancreatic duodenotomy or hepatic jejunostomy. It is not so common, but it occurs in up to 13% of cases. And the problem is that the patient had problems with the pancreatic and biliary, as pancreatic biliary dysfunction, to the cholangitis, ascending cholangitis, to the stasis of the juice in the jejunal limb. And this is a case, one of the cases in which the patient had a recurrence of a pancreatic cancer after pancreatic duodenotomy. You can see how dilated is the afferent loop, jejunal loop. And under EUS, from the gastric or the jejunal limb, you can see the limb that is very dilated without the need of injection. And you can release the lamps under EUS vision, anchor to in this case, to the stomach wall, and to let the juice, bile and pancreatic juice filling the stomach. And you can have an X-ray control after the procedure. You can see the lens, you can see the injection of the afferent loop, jejunal loop, but also the injection of the biliary tract, because the patient has a hepatic jejunostomy. Another indication for enteroenteric anastomosis is the gastric outlet obstruction. Of course, in these cases, the altered anatomy is due to the neoplastic disease, benign or also malignant, as I told you before. The problem is that the gastric outlet obstruction leads patient to a clinical rapid deterioration, weight loss, and moreover to stop all oncologic therapy. And so we needed to treat it easily. Three techniques have been described. One is the direct EUS technique. In this case, we have the dilation of the jejunal limb, identification that can be visualized from the stomach. And you can see that is it filled, or you can puncture with a 19-gauge needle in order to distend this limb and to target the perfect jejunal limb. Then you can, okay, the video now it runs. You can puncture the limb. You can use saline solution to make a better distension of the limb. then we can aspirate the juice in order to be sure to be in the right place. And you can introduce a guide wire and to release with a free hand the lamps. The other technique is the West technique that is the widely suggested in the ESG guideline. You have in this case to bypass the stricture with a catheter over a guide wire and to set the catheter, the nasobiliary or nasojejunal tube at the trites. The trites is a very right place because it's fixed. You can see with under EUS supervision the catheter, and moreover is very close to the gastric wall. Under EUS supervision, you feel the jejunal lymph. You can use also some glucagon or buscopan to reduce bowel movement. And then with the free hand technique, you can release your lens and anchor the distal flange into the jejunal loop, anchor to the gastric wall, as you can see in the video. Retrieve in a classic release and to release it into the stomach to perform a gastrojejunal. And then the device-assisted technique in which you use this special device balloon, but it's not available in Europe, only in the Eastern countries, or a classic series balloon, just identify and to fit the jejunal loop. There are many issues about the difficulty in bypassing the stenosis because sometimes in the third duodenum is not so easy if the stricture is long to bypass the stenosis and so to put a catheter across it. And the problem is the distension of the jejunal because sometimes the target is not so big like we are using the gallbladder or in the pseudocyst, and so is not so difficult to is not so easy to release the lens. Once again, ESG recommend the use of saline instillation for small bowel in order to distend the loop as much as you can. The risk of misdeployment is not so low, is described around 10%. The problem of misdeployment is in this case, the patient are always fragile, and so we have to close the gastric hole if we have misdeployed the lamps to retrieve everything to close the gastric hole or to refer patient to surgery in case of the lamps released in the peritoneum. Sometimes it is suggested also to use a therapeutic endoscope through the gastric hole in order to retrieve the lamps deployed in the peritoneum. What about the outcomes? In the first series, there were no difference in the technique. However, in the technical success of the series. However, compared with enteral stents and surgery, EUS-G anastomosis performed better in terms of technical success and in terms of clinical success compared with the enteral stents. Two reviews have been released in 2020 and confirm this data: technical success around 92%, clinical success 90%, and adverse events around 10-12%. Another one also published in 2020 with a technical success, as you can see, around 90 to 100%, clinical success higher than 90%, and adverse event from 10 to 15%. In conclusion, endoscopic ultrasound guided enterointerostum has emerged as an alternative technique to surgery and enteral stent in altered anatomy, both benign and malignant indication. Is a minimally invasive procedure not to consider in patients fragile or not fit for surgery. And the adverse events are lower compared to surgery with a very good technical and clinical success. However, it remains a challenging procedure, and so ESG guidelines suggest to perform only in experts' hands and after a multidisciplinary discussion. Thank you.
Thank you very much, Elena, for your excellent presentation. I think we will move forward with the next presentation as previously discussed, and at the end we will have some time for questions. So thank you again. And now we will move with our next presenter.
Morning. From my side as well, thank you for the kind invitation to talk, and it is a pleasure to be in Marseille, albeit from Leuven. I also want to congratulate Helga for an excellent overview. So in my talk, I will be specifically discussing therapeutic endoscopic ultrasound in the management of biliary obstruction. And I want to pose the question, is it not time for us to really rethink biliary drainage? It really comes from the fact that we are now seeing patients with malignant biliary obstruction surviving longer. Some of these patients are really outliving their stents. And very often, if patients need to come back for additional stent placements, they may end up having so many stents in the bile duct that we really cannot do anything anymore for them. And these patients may ultimately succumb to sepsis rather than malignant disease progression. So I want to pose the question, really, is it not time for us to consider, is it still justifiable to just place biliary stents without considering the therapeutic response and the natural history of a malignant disease? And this is a prime example of what I want to discuss with you today. A patient that presented in 2019 with a cholangiocarcinoma. The patient was inoperable, and because of a Klatskin 3B malignant lesion, stents were placed that ultimately obstructed, and more stents were placed. I think we are now sitting with 4 or 5 stents in the biliary tract. Endoscopic therapy is no longer feasible, and the patient again was only good for a while before presenting again with recurrent cholangitis, before the patient was referred to us for endoscopic ultrasound drainage of the left lobe. But even in this case, we are left with segments in the right liver lobe that are not drainable, and this patient will not be helped as much with endoscopic ultrasound salvage therapy. So this really speaks to the principle that we should rethink the way that we are managing these patients. I do not need to tell the audience that endoscopic ultrasound has really changed the management of so many diseases. It allows us to access areas that are previously inaccessible. And from the beginning, it was really used as a therapeutic modality more commonly in the setting of pancreatic fluid collections. And for some or other reason, endoscopic ultrasound has really been slow to progress beyond pancreatic fluid collections to other therapeutic indications. But we have seen, as Helga is so well illustrated, an absolute surge in the development of therapeutic applications, and now they're also backed by good quality evidence. When we now can give talks at conferences and to discuss the applications of endoscopic ultrasound, it is backed by good quality evidence across the fields of transgastric biliary drainage, pancreatic duct drainage, gallbladder drainage, and enteroenteric anastomosis. And I think that was really the reason why ESGE asked us to write guidelines on this, to really portray the current state of therapeutic EUS, but also define the need going forward, what we still need to achieve. So sticking to the principle of EUS-guided biliary drainage, I'm sure that you're all familiar with the fact that ERCP will fail in about 10 to 15% of cases. Very often in expert hands, there will be a reason for that because of duodenal invasion or in cases of surgical anatomy. So there are two huge principles that I think we need to discuss, and that is the first principle that in some cases one can manage to advance the duodenoscope up to the level of the ampulla, but biliary drainage fails or biliary cannulation fails. And the second scenario where, because of tumor invasion, it is simply not possible to reach the papilla. And then the third scenario, and that is the altered anatomy scenario, where we have patients that have received previous surgical interventions, where it is not possible using a conventional duodenoscope to reach the biliary tract, and that means that these patients are left to for us to consider other therapeutic options. In the past, we would have considered sending these patients to the interventional radiologist for percutaneous drainage, but I want to remind you that percutaneous drainage is associated with a mortality of up to 5%. The interventional radiologist will need to traverse the parietal as well as the visceral peritoneum, and these patients will often have pain following these procedures. It is not possible when ascites is present, and it greatly affects the quality of life, especially if we cannot internalize the drainage following initial placement. So this has led to the development of EUS-guided techniques, and I'm going to just briefly discuss the principles of EUS-guided biliary drainage. We normally would use a standard linear therapeutic EUS scope, and we would position the scope either in the duodenal bulb or in the proximal stomach, where it is then possible to identify dilated bile ducts from these positions and allow us to cannulate and perform therapeutic procedures. There are two principles regarding EUS procedures. The one principle is that EUS may be used as an assisted tool. In this case, EUS will provide access to the biliary tract, for instance, using a guide wire in the form of a rendezvous procedure. And in this setting, EUS really assists us in performing an ERCP. So after the wire has been placed, the physician will switch to ERCP, to the duodenoscope, and alongside the wire or extracting the wire externally, an ERCP can be performed. So that would be called the EUS-assisted technique. The EUS-guided technique would refer to us using EUS to perform a therapeutic procedure, and there are three procedures that we can perform, allowing us to drain the bile duct. The first procedure is the EUS-guided choledochoduodenostomy, where from the duodenal bulb we would access a dilated duct to place a stent. The second procedure that we may utilize is from the proximal stomach. We can cannulate a dilated biliary tract using a 19 gauge needle and place a stent between the left system and the stomach, the hepatogastrostomy. And then, in my opinion, a very underutilized technique, and that is to use EUS to advance a guide wire across the malignant stricture into the small bowel so that a stent can be placed antegrade across the malignant stenosis into the small bowel. The advantage of this technique is that no fistula is created, that you would respect the normal anatomy. In the setting of hepatogastrostomy, you will divert away from the malignant stricture bile towards the stomach. And there are good indications, in my opinion, where these techniques may be considered. They are not mutually exclusive. I'm not going to talk about gallbladder drainage and not about EUS-guided gastrogastrostomy that was so elegantly done by Dr. Bertrani. So the principle of performing this technique from the proximal stomach, we would position the endoscope. We would then identify dilated bile ducts. We would advance the needle, and then under endoscopic ultrasound guidance, the needle will be very carefully advanced into the bile duct. We would make sure that we can see the needle in the bile duct, and if that is confirmed, we will and can aspirate bile to confirm the position if that is necessary, and I would certainly advise that when you begin with this procedure, following which we can inject contrast to identify the anatomy. In the setting of rendezvous, we would utilize rendezvous ERCP very often, rendezvous EUS assisted techniques very often in the setting of benign disease, where we do not necessarily want to compromise the biliary anatomy in patients, and in this setting we would advance a wire very carefully from the proximal stomach across a stricture, in this case a benign stricture, to the small bowel, and then exchange the scope. We can then advance the duodenoscope, and we can cannulate alongside the wire or extract the wire using the duodenoscope for therapeutic procedures. And very often this is utilized in the setting of benign disease. In the setting of choledochoduodenostomy, a prime example of this is when the bile duct is dilated. It's in very close proximity from the duodenal bulb normally to the duodenal bulb, and it is fairly easy in most of these instances to place a stent, a choledochoduodenostomy stent. I think that at the moment there's a lot of hype about this procedure, but I think we have to be more realistic in the future, because this procedure can be complicated by cholangitis. There is a good reason why the surgeons stop performing this procedure, but it can be a useful procedure in certain settings where biliary drainage is required. But I think time will tell to what extent this procedure will stand the test of time. In the next video, I want to just show you from the proximal stomach what we normally can achieve. Very often by advancing the wire, it can be fairly easy. In this case, a very, very tight stricture it was quite easy to pass with a duodenoscope, which allowed characterization, which allow us to obtain cytology if necessary, and then for us to consider, are we going to place a stent antegrade, or are we going to drain towards the stomach? Those all remain options under these circumstances. And finally, when the anatomy has been clarified and the anatomy has been, we have achieved our goal of advancing the needle across the stricture, we can, in the setting of an antegrade stent placement, place the stent across the stricture and then open the stent as we would normally do when we perform this technique using ERCP, except this will be done in a reversed fashion. In my opinion, there are certainly advantages of this technique, because if you place a stent in this way and the stent should occlude, you always have hepaticogastrostomy as a potential salvage procedure. In the setting of hepaticogastrostomy, an example where we would puncture the needle, dilated left segment, and then advance a needle. In this case, it's a patient with an hepaticogastrostomy, where it's in the setting of a benign disease, a stenosis of the hepaticogastrostomy, and after placement of the wire, manipulating the wire across this tight stricture, we managed to obtain cannulation. This allows us to place a fully covered stent and then allows us to remove the stent after a week, and we have a tract from the stomach that we can then go back into the anatomy to define the cause of the obstruction, to remove stones if necessary, and to drain the anatomy. So you always have a gateway towards the dilated bile duct. So what is the evidence that we have regarding EUS-guided biliary drainage? Well, I think we now have randomized controlled trials. We've got meta-analyses, and as summarized in the publication in ESGE, we have now more than 900 treated patients in studies where we can show that the technical success and clinical success all are more than 90% for choledochoduodenostomy, and similarly for hepaticogastrostomy in the setting of malignant and benign biliary disease. If we consider comparing choledochoduodenostomy with EUS-guided hepaticogastrostomy, one can see that the outcomes are very similar with regards to technical success and clinical success, with us having the option of choosing for the particular patient the best therapeutic option. So coming back to the key question that I wanted us to define and to try to answer in this talk, is it not high time to redefine biliary drainage strategies? And I again want to emphasize that we now need to consider not only that it is technically possible to place a stent using a duodenoscope, but we also need to consider the natural history of the disease, the likelihood that that patient will respond to therapy, with now also with the advent of immunotherapy, that to answer those questions have become more and more difficult. I want to take you through what I propose maybe strategies in the future that we may want to consider going forward. In patients with distal malignant obstruction, we can either place a stent via ERCP. If ERCP fails, we can place stents from the proximal stomach or place a choledochoduodenostomy, depending on the clinical scenario. More difficult to decide will be the patient with a subhilar stenosis in the setting of a patient not being a surgical candidate, where the left and right systems may still be communicating. And in this case, it may be quite interesting if we would consider drainage of bile away from the primary tumor towards the stomach and allow us the opportunity because of the fact that these stents will be very less likely to occlude, given the fact that we are draining away from the tumor by connecting the dilated left system to the stomach. It may become more complicated in bismuth 3 and 4, and in this case we may consider to drain the right system by ERCP, but avoid double stents or by deciding or obtaining for stent drainage away, again making sure that the left system is adequately drained away from the hilum. This may allow us to achieve longer stent patencies and less likely scenario of stent-in-stent placement for cholangitis and obstruction in the future. Or we may even have a scenario like this where we would opt to adequately drain segment 5 and 8 as well as segment 6 and 7 using 2 stents, but opt for also draining the left system to the stomach to obtain complete and adequate biliary drainage to make sure that these patients are adequately palliated. And then the scenario of double obstruction where we have the opportunity to, in the same session, drain not only the obstructed duodenal segment due to the ingrowth of tumor using a gastroenterostomy stent placement, but also have the opportunity to at the same time drain the bile duct if necessary to the stomach. So it becomes a complex scenario, but with the advantage of EUS and the advances made in EUS endoscopic therapy, these scenarios are no longer fantasy, they have become reality. So in conclusion, Mr. Chairman, therapeutic EUS has now become an established alternative to percutaneous drainage when ERCP fails, may even be the preferred method of drainage instead of PTC. There are various EUS-assisted and EUS-guided approaches available to the endoscopist, but we should definitely avoid multiple stents that may compromise survival, and certainly in the era of improved oncological outcomes, it is really time for us to reconsider by a careful decision making and deciding which segments to drain up front and not just go ahead and place stents in the bile ducts without considering the consequences that these stents may have. So careful decision making, taking into account all aspects of the care of the patient, including the likelihood that the patient may survive longer than expected. And in this case, I think EUS may offer certainly additional value over and above the standard of care that is currently in place. Thank you very much.
Thank you, Schalk, for your presentation. And
Thank you.
I think it's very important that you show for the Klatskin tumor. We need to combine all the possibility to drain. Why? Because the paper that we published, we show that we need to have almost 80% of the liver drain. This increases the survival time of the patient, and also if the patient is very well drained, he can receive a chemotherapy, he can receive treatment. And this is very important, not only for cholangiocarcinoma, but for metastasis from, for example, for breast or for colon cancer, that we have effective chemotherapy for this patient. And I feel I'm fully agree with I agree fully with you that the schema that you, the draw that you show, this is the future. And before to start, we need to have a plan to drain the right, to drain the left, but to have almost a large amount of liver segment drain.
Yeah.
Thank you, Mark. I couldn't have said it better myself.
Yeah, following this line, Schalk, you have proposed the anterograde biliary drainage as a possibility in some cases. In these cases, you are combining with hepatogastrostomy, or you are doing only the anterograde stenting? Because sometimes one can argue that the anterograde stenting can be also done in a second time after doing hepatogastrostomy, avoiding manipulation of the guide wire and avoiding eventual complications. So what do you think at this point?
I would rather argue the opposite, Enrique. I would rather argue that to drain distally first in some instances, for instance, in distant tumor, in the distal bile duct or ampullary tumor, not accessible by ERCP, and you have the opportunity to effectively even place a covered metal stent, and then if there is dysfunction afterwards, you may always elect to place an hepatogastrostomy as well. So I think in those settings, by choosing upfront your strategy, you may benefit the patient. Of course, if the small bowel is completely invaded and there's no opportunity for you to place a stent without that stent becoming occluded very, very quickly, the logical option would be an hepatogastrostomy.
Okay, so you consider there is no high risk of fistula in the hepatogastrostomy perforation if you have correctly placed an anterograde stent? Absolutely. Okay, nice. Maybe a very short question for Helga too. I think it's very, very interesting to the overview you have presented regarding the surgical anatomy and the different surgical anatomies we can have, and it's mandatory to understand the anatomy of the patient before deciding the strategy of the drainage using LAMS. So the question for Dr. Bertani will be, how can you expect to decrease the risk of LAMS migration? Some kind of scope maneuvers or some kind of suturing or...
in the edge procedure, do you...
Yeah, mainly in the edge procedure.
Yes, but well, I think that in the edge procedure, the choice of the position of the lamps, it's fundamental in order to not dislodge during the passage of the duodenoscope. And so you have to choose the position not too far from the fundus, but as proximal as you can. Second, if you can wait, is better, because once the fistula has been created, the anastomosis is much more mature. Even if you have a dislodgement of the stent, the fistula is not, the risk of perforation due to the migration of the stent is low. So you can have a migration, but not a perforation, and so the risk of surgery later. You can fix, yes, the stent. This is one of the only one of the criteria that resulted is a significant difference in the recently published paper. However, I think that yes, it's a matter of cost. If the patient has a cholangitis, you have to be therapeutic in 24 hours or 48 hours. You have no time. It's better to fix. Otherwise, it's better to wait.
Thank you. We have one last question from quick answer, please, but one last question from the audience. Yeah.
Sure. Fauzi Malu Filho from São Paulo. Congratulations on those nice presentations. Dr. Bertani, you performed EUS-guided gastrojejunostomy. How do you follow the patient? You remove the stent, you exchange the lamps, or you just leave it?
For a benign condition?
No, for malignant condition. The patient survived 6 months, 7 months, 8 months. You intend to exchange the lamps or just leave the lamps were there?
No, I leave the lamps. I follow the patient by the clinics. Sometimes I have 2 patients who survived more than 6 months after replacement, and the lamps was still there. The problem is to help a patient with oncologic nutritional, because the patient do not with this stent have to maintain control weight, to not lose weight during chemotherapy, but also the consistency of the diet may be modified with him in order to not impact the lungs with food. You can follow, I do not follow up a patient routinely with the upper GI, but only on demand if some vomiting or patient's discomfort appears. And up to now, I didn't change the lamps.
Thank you.
Thank you very much. Well, thank you very much for both. And I think we finished this symposium. So now this is the time for lunch. Thank you again, Dr. Bertani and Professor.
Thank you very much, Dr. Bertani and Professor Schalk.